What's up, everybody? Dr. Alec here, and I'm with Tanisha. Tanisha is a recent addition, not like today recent, but in the last couple weeks recent, and she hasn't gotten her on-camera welcome adjustment yet. So that's what we're doing today. Tanisha, is there anything you'd like to say?
I'm excited to get adjusted by Dr.
Very
Alec.
cool. Is there anything specific that's bugging you that you would like me to pay attention to?
Neck and my shoulders and my lower back.
Totally understood. So let me get your face down.
All right.
We're just gonna get her full spine today. And I'm probably gonna get her neck in the chair lift, because I did that the other week and that seemed to really move it pretty well. So scoot up for me, get your face nice and comfy in the face paper. And Tanisha, remind me what your background is. It's exercise science?
Yes. Currently a junior, about to go into my senior year of undergrad at Towson for exercise science.
That's pretty sweet. And you want to be a physical therapist?
Yes, or a chiropractor.
Or a chiropractor.
Still, I'm dependent between the two still.
It's a tough choice. I support both. Take a breath.
Ooh.
That was a good one. Number 2 is pretty crunchy.
Ooh.
Could I get you on your side, facing me?
Yes.
You okay with that?
Yeah.
Nice. Was that your intention the whole time when you went to undergrad, or did you just actually have
Yeah.
Okay.
I started out as a dance major. Then
Seriously?
COVID hit. Yeah, and I changed my mind. I was like, yeah, no. And then I decided to do physical therapy instead. Whew.
Nice.
Because my physical therapist when I was in dance was a former ballerina. And that kind of inspired me to start working with PT, start trying to incorporate that with my dance training.
Was that your art form, ballet?
Yeah.
Okay.
I started dancing when I was like 5. Stopped when I was about 18.
That's wild. I didn't know that about you.
Yes.
Cool. Let me get you on your back. Was the intention to teach, or was it to do professional dancing?
I wanted to do both. I
Okay.
kind of wanted to do a professional career and then to teach, but COVID hit and my passions kind of changed. So now I kind of want to do PT and incorporate that, working with different dance companies.
I love that.
Thank
I
you.
really like that. Have a seat for me.
All right.
Take a look at that neck and then chair. You did it?
Yeah,
Okay.
it's getting
Good
stuck
Lord.
there.
Yeah, a little tight that way. Very tight. So you rotate all right there. Your whole SCM turns on when I turn you there. You do not appreciate lateral flexion into the right. Okay. Just keep your teeth together for me.
Okay.
I don't want to clack them. Nice. Probably a little more. Nice. You still good?
Yeah.
Last little bit down here. Yeah.
I'm telling y'all, my soul just left my body.
Make sure. Yeah. Dang. Whoa, okay.
Crunchy.
I don't think there's anything left in your neck to manipulate.
It's great. I feel great.
You good?
Honestly. Yeah.
Feel like that got it?
Yeah. Definitely.
All right, everybody. That was Tanisha's intro adjustment, on camera at least.
Yes. Thank you.
What's up, everybody? Dr. Alec here. And I am here with the woman who runs it all. The reason the lights are on in the practice, Tanya. I'm coming in cold. I don't know what's about to happen. Tanya, what do you need worked on?
It's really from just honestly sitting at the desk. It's my upper back.
Gotcha.
And my neck and my low back.
So your whole spine.
So my whole spine. Yes.
Gotcha.
Fortunately.
Can handle that one. Let me get you face down.
Okay.
And I'm gonna say I don't need to conduct a new exam on Tanya, because I've adjusted Tanya maybe more than anyone else here. Years. I've had years of practice on Tanya. You might have been one of the first employees to let me take some wax when I was a preceptor. Oh, wow. Baby, stop. Take a breath for me. And all the way out. Yeah. You okay there? Mm-hmm. That's pretty productive. If I gave you just one title for Tanya, it would be inappropriate because she has many titles. She does all things. Office manager doesn't cut it. Take a breath for me. And all the way out. Wow, sent you south. You good? Are you okay with where your face is at? Mm-hmm. Nice. Yeah, I tell you what, Tanya's CT junction gets pretty locked up. I don't want to rip her hair out in the process. Yeah, I'm just gonna get that on her back. All right, T, let me get you on your side.
Okay.
In case you were concerned about your hair getting messed up,
I really appreciate it.
it's already happened. Nice. That's great.
Yeah.
Maybe move better than usual.
That's good.
That is good.
Right.
Perfect. I know, not everyone does it this way. This is my way. Cool. You in one piece, Tanya?
Yep.
Okay. Love it. Sweet. I'm gonna go in for the hug because I know that upper back is killing you. Redirect. Tanya is a notoriously stiff up high.
I wonder why.
Because you are married to a computer.
I know.
That was a little better. Let's see what we got here. Nice. Dang. That's pretty productive.
It was.
Which thumb do you not like?
This one.
Nice. Ooh, crunchy. You okay? Mm-hmm. Yeah, I know that's not comfy. Well, listen, nothing out of the ordinary there, nothing complex. Did I miss anything, Tanya?
No, I think you got everything.
Okay.
I feel a lot better.
Oh my God, thank you, Tanya.
Thank you.
There you have it, folks, a full body adjustment on Office Manager Extraordinaire, Tanya. What's up, everybody? Dr. Alec here with Sabrina. And today we're going to be talking about what I could broadly call a benign acute torticollis. And I quantify it as benign because for any clinicians or students out there listening, I understand that a torticollis has many other acute causes. So if you happen to notice that you have an intense new onset of headache, swollen lymph nodes, paresthesia, numbness in your extremities, if you're having difficulty speaking, formulating words, swallowing, or using the restroom, then this video is not for you. But if you are the kind of person who went to bed perfectly fine, woke up in the morning with your neck in shambles, almost completely unable to turn your head to one direction, this video is for you. So we have someone in the office who this happens to actually on a fairly regular basis. So Sabrina, in your own words, what do you experience with a torticollis?
So I'll wake up in the middle of the night, my neck is very stiff, like I'll kind of wake up in an awkward position and then like turning my head just like feels so stiff that I cannot move. And it hurts down through my traps, like to my rhomboids, like almost like mid-back.
Gotcha.
So like, yeah.
Yeah, it's excruciatingly intense. Trying to rotate your neck with a torticollis is unbearable to painful at best. And so from a technical standpoint, what's happening is your body is attempting to offload a contralaterally irritated facet. So what you're gonna see is a lateral bend and a contralateral rotation away. off of the irritated facet, and then any movement away from that offloaded position is going to be incredibly painful. It's a pain spasm cycle at the end of the day is what a torticollis is. So from a diagnostic standpoint, a lot of this is history, a lot of this is conversation, and frankly, there's not many orthopedics to do because the neck can hardly move. But in the absence of a paresthesia with acute axial spine pain, in a history like you just went to bed fine and woke up in pain, pretty confident, at least I'm comfortable with a working diagnosis of acute torticollis. So the way we would start with treatment is, typically I would start with soft tissue. So let me get you on your back. You can't do too much too soon with a torticollis patient because they just won't let you. But I'm gonna do a little bit of soft tissue work. We're gonna do some PNF stretching, some contract relax stretching, and then we're gonna head over to the dry needle bay, because at the end of the day, this is an overactivity of the sternocleidomastoid, the levator scapula, and the trapezius, all kind of working together to crank your neck in that opposite direction. So those muscles kind of have to be released so you can at least give the facet joint that's irritated the biomechanical opportunity to not be cranked down in that pain spasm cycle. So for the sake of, just for the sake of today, let's pretend that she has a right-sided torticollis or is experiencing pain on the right side of her neck. So I would just come through here, and it's important to remember that the levator scapulae, although it is an upward rotator of the scapula, and one of its attachments is down here. The levator scapula anchors on the transverse processes of the top 4 cervical vertebrae, so it ends up being important to do a lot of work up top. Is that tender up there for real?
Yeah,
is this the side you actually have pain on?
Both sides,
Both
but
sides.
like it's very tender.
Ooh. So I might be taking a little bit of a liberty with Sabrina's neck. Someone with a torticollis might not let me move it quite this much. You okay with that?
Yeah.
Can you say it's this side as well? Mm-hmm. Bilateral? My lord. Okay.
Well, how often it happens, it just
I feel like it happens once
on
every
both
6
sides.
weeks.
Monthly.
Monthly.
Maybe.
So it's hard to say. It's hard to say what exactly causes a torticollis because you're sleeping while it happens, but it's common if you have a window open or if you have a particular side of the room that the fan is on. So essentially, like the direction of draft. In your sleep, you turn away from that and end up irritating the facets on the side you turn into. So that's maybe something to keep in mind if you keep getting a torticollis on the same side of your neck. So this is me working on her traps a little bit. You okay?
Mm-hmm. My traps are tight.
Good Lord. They are tight.
Mm-hmm. You feel it jumping?
Yeah, right there. Oh, my Lord.
It's all good. It's all good.
Yeah, it's all good. All's well that ends well. And you said you got one, was it Saturday?
Yeah.
Maybe a little one, a baby one?
What was it? Saturday? No, Friday. I guess
You woke up Friday morning a little irritated.
a little bit, and then it was worse Saturday morning. More so, like in the middle of the night. I'll just wake up because I'm uncomfortable.
I got you. So it's gonna maybe lack a little bit of relevance because she's not in acute spasm, but a way that I could get through a neck that is spasming harshly is I would say, Sabrina, could you push your head into this hand? 5, 4, 3, 2, 1. You could stretch it a little farther. And this is that stretch, relax, that contract, relax kind of stretching. And then from this new position, I would say press into my hand again. 5, 4, 3, 2, 1. Relax. And I could kind of strip against that as I stretched her farther. You okay with that?
Yeah.
Okay. So I'm gonna come in and get her first rib. Look to your left for me. Grab that opposite shoulder.
Ooh,
Amazing.
she crunchy.
Very crunchy. to your right for me. She's not nearly as stuck on that side.
No.
So I'll probably get that when she's face down in 2 seconds. And sometimes it can be difficult to manipulate someone with torticollis, and I may not manipulate on the first visit, but if there's any give after doing that PNF stretching and some of the soft tissue, I'm gonna at least try to take what she'll give me. So if she's already rotated this way, I'm pretty comfortable that her body's gonna let me adjust into it. Really clean. Nice.
Nice.
So then, just to finish up in here, let me get you face down real quick. Good, sorry for messing up the makeup.
Oh yeah, come on now. And my hair.
I know.
Oh man.
Apologies.
Oh, let me move this. Oh, fella.
You okay?
Now I'm good.
Lots of freebies. So take a breath for me, Sab. Nice. You okay there?
Yeah, I feel like there was more freebies than.
More freebies than what I went for. Okay, so that concludes what I do in the room with someone with torticollis. The next phase of this is to head over to the dry needle bay and get those muscles that I talked about. So I'll see you there.
Realize how much I actually needed that.
Do you feel better after that?
Yeah.
Okay, I'm glad. Why do you keep that to yourself?
I don't know. I just like deal with discomfort. And I go on, and then I forget about it.
You're a
'cause I'm
soldier.
Dealing with other people's discomfort.
That's what we do. Okay, so to go back to the anatomy I was talking about earlier, I'm first going to dry needle her levator scap. I'm also going to get upper trap too because it's layered, and with the needle you're going to penetrate both. So I come up really high. I find the spinous process. I slide a little lateral. I know I'm on the transverse process. You okay with that, Sabrina?
Yes.
Okay. And just because she has a little bit of that bilateral pain, I'm going to do it on each side. But I'm at least going to try to address these first 4 cervical vertebrae with a needle. Nice. You felt that one.
That's a zinger.
That was a zinger. So as is pretty typical, that was another huge one actually.
Ooh.
Huge zinger. So I'm really confident that that was actually like a levator scap trigger point because I could feel her twitch kind of down there too.
That was crazy.
That was crazy. So it turns out your levator scap is legitimately irritated. Okay. So that's the upper part of the levator scap, and then I come in here, I find the superior margin of the scapula. Where is she at here? Yeah. And so the levator scap inserts right around the corner of the scap, just superior to the spine of it. So I'm going to be careful to sink a couple right. Nice. Right where I know the levator scap lives. Perfect. And then I'm going to slide just a little superior. And I know this is still upper trap, maybe partially mid trap, but certainly mid trap as I get into this region. I'm also going to get her trapped on the contralateral side just because she's dealing with some stuff there.
Ooh.
Another huge trigger point on that left trap. Okay, so I'm really comfortable with the needles we have in Sabrina right now. I peppered all the major muscles. If I was feeling adventurous, I might even sink a couple in the SCM, but I'm comfortable that I addressed it with the PNF and soft tissue work in the room. So I think I'm just going to leave it at levator scap trap and What else did I do? Like levator trap, scapula, levator scapula trap. Okay, yeah, I got them. So she's going to cook for 10 minutes. And this is how we would treat a acute torticollis. If this is something that you have or something that you feel like happens to you regularly, it usually happens to women more than men, although men can get it too. Feel free to stop on in. So how painful a needle is it's usually indicative of how irritated the tissue is underneath. I could also be puncturing like a cutaneous nerve, and in that case, it'd be painful every time, even though there isn't any like underlying dysfunction. What's up, everybody? Dr. Alec here with Chiropractic. So I got Britt face down, and you probably watched a video just a little while ago of me examining and adjusting her. And I think I came to the conclusion in that video that this arm pain, this kind of nebulous, weird arm pain that she experiences is most likely coming from her neck and is in fact not some sort of peripheral entrapment. And as time has gone on, the evolution has been that that's probably more true than not. So I am going to treat her today as if this is a neck complaint, a cervical radiculopathy. So I'm going to dry needle the paraspinal musculature at those levels of her neck. I'm going to get the interspinous space. I'm going to kind of come down into this trap, and I'm almost just going to trace the line of discomfort that she has, and I'm going to finish kind of here in her medial brachium. So we'll just go ahead and get started. And you're experiencing this like every day, Brett?
Yeah.
Yeah.
Yep. Yeah, it used to only be mornings, but now it's like throughout the day.
Dang.
Yeah.
It's kind of hard to tell. With Britt, there's a couple different distributions that it seems like are potentially affected. C7, C8, T1. So pretty much her entire lower neck and yowza, right?
Yeah.
And potentially upper thoracic spine as well. You're not getting any like distinct weakness though in your arms, are you?
No.
Okay. So those first three that I sank were interspinous space needles. I just do that because sometimes these over-facilitated segments can be coming from like that interspinous ligament, and I want to give these segments every chance I can to breathe if they are in fact compressing or compromising neural structures like the root. You doing okay?
Mm-hmm.
I know. So how painful a needle is it's usually indicative of how irritated the tissue is underneath. I could also be puncturing like a cutaneous nerve, and in that case, it'd be painful every time, even though there isn't any like underlying dysfunction. But so that was a huge trigger point.
Yeah.
And it's pretty common for there to be some pretty powerful trigger points in the trap with a lower cervical radic. This is me sliding into some of the parascapular musculature too that can be implicated in something like this.
Or the older spots are starting to like act up or something.
Wait, say that one more time?
One of the needles that you had put in a while ago.
You're starting to feel it?
Yeah.
Oh, yeah. So this is her scapula. So that's just me sliding into some of those cuff muscles, actually. And then as promised, I'm going to come down into her medial brachium. It tends, for her, it's almost biasing like her bicep as opposed to her tricep. And I'm just palpating every once in a while to make sure that I'm not hitting that brachial artery. She wouldn't appreciate that too much. You okay with this, Brett?
Yeah, that last one was a little...
Little dicey? Mm-hmm. Okay, well, I'm feeling confident that we sunk the needles we needed to sink today to affect the tissue that is likely causative in her cervical radic. So we're going to let her cook for 10 minutes here, and maybe we'll shoot another video in the future if we figure out something else to do to Britt.
Getting ready, Lucy, goosed up.
Okay, I'm ready when you are. We're playing. Okay. What's up, everybody? Dr. Alec here. I'm here with Kaylee. And today we're going to be talking about and treating hip flexor dysfunction. So that is a very broad term that could be divvied up into lots of anatomically specific causes, but today I'm going to be addressing the kind of hip flexor dysfunction that is specific to like a sensitization of the psoas tendon that is secondary to either repetitive overuse from sitting or repetitive overuse from things like running or lifting weights. So this all starts with an exam. So Kaylee, could you get on your back for me, please? So your hip flexor originates on the 12th vertebrae of your thoracic spine, anchors on several other vertebrae, then dives through your pelvis and anchors itself, it inserts itself on your femur. So if you are feeling pain kind of in your groin, right in the crease when you fold your leg, that's essentially right where your hip flexor is. And Kaylee just revealed that you did have...
I did. I don't know what I did, but in college, the right one, I had to take weeks off of field hockey for it.
Can you point exactly to where it hurt?
Here.
Like,
so yep.
Right there.
Yep.
Yeah. So if it's true hip flexor pain, it's going to be beneath. It's going to be inferior to these bones of your pelvis. If it's above, it's probably more of a like a legit abdominal issue. But that is definitely in the hip flexor region. So to examine a hip flexor dysfunction, there's a couple ways to do it. Someone who has a dysfunctional hip flexor, they're going to have pain when you start closing down. But she has an excellent range of motion, so probably no pain there, right?
No.
You sure?
Yep.
Okay. They're likely going to have awesome external rotation because that's opening up this relationship between the femoral head and the acetabulum. But when you go into internal rotation, so you have out of this world internal rotation.
Still gets it though.
You felt a little pinch in there?
Mm-hmm.
Okay. So most people, frankly, if you push hard enough, you're going to feel a pinch in your groin if you internally rotate your hip enough. But I would say that yours is well within, maybe exceeds normal limits.
Sick.
Pain there?
Mm-mm.
Pain there?
Mm. Crazy.
Good there?
Yeah.
Okay. Someone with hip flexor dysfunction might also get a little bit of pain with this figure 4 move. You're a little tighter in that. This is not as sensitive though because this kind of motion can be inhibited by some of the more posterior musculature too. Do you feel any pulling in the front of your groin there?
A little bit here, but not like crazy.
Okay. And then just something else you can do. In a perfect world, we do not have the ideal table to be doing this on right now. In a perfect world, we'd be on like a massage table where I could get her to scoot her legs to the crease of the end. Yeah. And sometimes when people's hip flexors are really tight, so something else I need to say. Another prime hip flexor is actually, it's your rec fem. It's one of your quads where it anchors, it crosses the hip joint. So although it's not that iliopsoas muscle that dives through your pelvis, your rec fem can sometimes act as, it does act as a hip flexor. So if you kick a leg off to the side like this and you notice that someone's leg is a little too extended, you might be able to implicate the rec fem in that too. Okay, so here's how I'm going to treat this today based on the fact that she has just kind of, honestly, relatively benign run-of-the-mill hip flexor pain. I'm not going to dry needle her. I'm not going to use shockwave. That's for something more like a psoas tendinopathy. But what I am going to do is some very uncomfortable soft tissue work where the belly of the muscle, belly of the psoas is in her abdomen. And then I'm going to kind of work down into her groin too. So for that, I'm going to need to get some help. Be right back for that.
Rock on.
Are you right?
I'm so excited. No.
Could I get some help, please?
Did I make a floppy fish?
All you have to do is a little psoas for me, bud.
Did you say so fish or so selfish?
So fish of you.
So fish of me.
Love it.
All right, let's do it. Let me get you on your side, facing that way.
You're obsessed with that song, bro.
Yeah. Theory or?
No, psoas.
Oh yeah, you said that.
Psoas. Okay, tell me when you're filming.
I've never stopped.
Oh, wow. Okay. So the way we're going to start a psoas release is we're going to get Kaylee. Have you ever had this done before?
No. It's going to be so fun and exciting.
This is going to be a really, this is going to be novel, to say the least. So we start with a nice flexed hip, and then I'm going to essentially come in. I'm going to slide the viscera out of the way. I'm going to weasel my way between the obliques and the rectus abdominis. I know it's not comfy, but I'm going to run. Yeah, she's kind of feeling me get there. There.
Oh my God.
That hard band that I found, that is your psoas. It's all the way up there. So Dr. Jonathan is slowly going to extend the hip while maintaining downward pressure. It's really intense. He's going to push down, so he's going to adduct the hip. Amazing. And you're going to reach over your head with your right arm as far as you can. So that's really going to just elongate. Wow. Yep. So there's one rep. You okay there?
Yeah.
You sure?
I just need to breathe.
You do.
Yep.
Okay. So now I kind of know what I'm doing. I'm going to weasel my way down into a more lower part of that belly. She's going to feel it in 1 sec. Go for it. There. Reach that arm overhead for me.
I forgot.
Yeah. I know you don't appreciate that all that much. It's a little wild.
That one's freaking crazy.
It's crazy. So for this next one, I'm gonna like grab her ASIS, curl in, and try to pick up a little more of that iliacus, which is a different flavor. Go for it. Give me that big reach. I know that's super special. Amazing. And just for the very last pass of this, I'm gonna come right onto the tendon itself.
That feels funky.
I know it feels funky. Go for it.
How fun.
And then reach. Frankly, this is probably the least intense one of all.
100%.
Amazing.
Wicked.
You okay after all that?
Yeah.
Thank you for your aid, Dr. Jonathan. I appreciate you. So now at this point, now that she's loose and I know that the musculature of her mid-low back and hip is super extensile, I'm going to adjust her.
Oh, word.
And we recently got an MRI of Kaylee's back that probably warrants another video. She has some very funny looking joints in her low back.
Dude, it went so bad already.
It literally already went. Let me get you on the other side though.
Oh, well.
She has exceedingly coronally oriented facet joints, which means that her lumbar spine successfully rotates but does not flex and extend very well, which just means we have to adjust her in a more... Wow. I'm not even going to beat that up. Let me get you on your back. Yeah, she's different. And what goes with that is she's also the kind of person who likely doesn't need a lot of spinal manipulation. She does not have a mobility issue. She has a stabilization problem at the end of the day. Nice. Cool.
Fun.
You cool with all that?
Heck yeah.
Okay. So listen, that was fun. So that was a really quick and dirty approach to hip flexor pain. There's many rabbit holes we can go down to determine whether this is labral, is this an osseous abnormality, is it a legit psoas tendinopathy, is it referred pain from your lumbar spine, do we have a nerve caught up in the hip flexor? There's a lot of different possibilities here, but in the case of someone who has really benign hip flexor overactivity, like someone who sits or runs a lot, this is exactly how we would treat it. Thank you so much for watching. Don't forget to subscribe. Bye-bye.